I'd like to introduce Pushpa Kalra, who will introduce our session for today.
Good morning. It's my pleasure today to introduce Dr. Fred Southwick from University of Florida. He received his BA from Yale College and MD from Columbia. He received clinical training in Boston City Hospital and the Mass General Hospital in internal medicine and infectious diseases, and served on the faculty at Harvard and the University of Pennsylvania before coming here as Chief of Infections at the University of Florida. He served as Chief of Infectious Diseases for 19 years. Currently, he's Professor of Medicine and the Director of Patient Care Quality and Safety for the Hospitalist Division at UF. He has published over 100 papers in peer-reviewed medical journals and is the author of 2 textbooks, one on infectious diseases and another one on critically ill, a 5-point plan to cure healthcare delivery. He has been teaching 3 massive open-line courses to over 40,000 students, and the course is entitled Fixing Healthcare Delivery 1 and 1.0 and 2.0, and COVID-19, a clinical update through Coursera. I don't know what that is. He was an NIH-funded investigator for over 30 years, studying actin-based mobility, the pathogenesis of listeria and anthrax. He is a member of the board of scientific counselors for the NIH, and I must add that yesterday he became an author of Gainesville Sun. He had a column in the Gainesville Sun in yesterday's newspaper. Welcome, Fred. Thank you for doing this.
Good. Thank you, Pushpa. It's wonderful to see everybody. And actually, my talk is going to amplify the op-ed. And ironically, I gave a similar talk to this about 4 weeks ago. And I began to think about it in more detail. And as a consequence of my original talk, that's how I ended up writing that op-ed. So the question that I want to answer, in this talk is why has the U.S. failed to close Pandora's jar? And I'll explain Pandora's jar a little bit later. For those that know Greek mythology, they will understand what I'm talking about. So this is yesterday, the map from the Centers of Systems Science and Engineering of Johns Hopkins, looking at the total number of cases in the world and the total number of deaths. So there are 246 million cases and nearly 5 million deaths. So worldwide, there's a 2% death rate based on these statistics. And the US leads the world with 46 million cases. India is number 2, and Brazil is number 3. And if you look at this in a little more detail, remember the US represents 4% of the total world population. And yet, when it comes to death, we represent 14.9% of the deaths, or 3.7 times excess mortality compared to other countries. Brazil is the only country that beats us in this category, and that they have 12.4% of the deaths, and their population only represents 2.7, so 4.6. Now, India, which is resource poor and has a relatively weak health system, represents 17.7% of the world population and 9.3% of the deaths, so 0.5. So they have half the number of deaths compared worldwide for their population. So one of the important things to keep in mind, I just want to refresh your memory because this is very relevant to the problems we've faced, is that this virus, there's no question that it's almost strictly spread by aerosol and droplets. And the big problem, which you didn't understand at the beginning, but we understand very well now, is that individuals are carrying high concentration of the virus without having symptoms. There is a period after exposure, usually about 3 to 4 days after exposure, and 2 to 3 days with the Delta variant, where the individual will be spewing high concentration of virus without symptoms. And then in the first 2 or 3 days of symptoms, they're also highly infectious. And there's been this big debate about droplets versus aerosol. Really, it is a continuum. When we speak, when we sneeze, we create large droplets, which do fall to the ground within 6 feet, but we also create a large number of smaller, finer particles called aerosol, and anywhere less than 5 to 10 microns. And what's important about those, and I think those really have studied this disease, feel that the aerosol is probably the predominant issue when we're talking about indoors. And these droplets can create a cloud, and that cloud will stay up in the air for 3 to 4 hours, and it can migrate far distances. So the 6-foot rule does not really apply for aerosol. And what really counts is how well ventilated a room is and how large that room is. And obviously, if you're outside, I think we've proven beyond a shadow of a doubt with all these football games that the aerosol does not play a big role, and individuals don't seem to become infected when they're outdoors. So the original virus, we had a reproductive rate, that is, one individual who was infected in general could infect 2 to 2.5 individuals. So you saw that R naught of 2 to 2.5. And the other important thing to keep in mind is that a high percent, 80 to 85% of infections are in families, in household, due to household contacts, which makes sense because individuals are indoors together, that aerosol can really build up in houses. And 53% of household contacts with the original virus would become infected. This was a CDC study about 6 months ago. And 75% of those infections occur within 5 days. Now, when the pandemic began to really show itself, the Imperial College had created a COVID-19 response team that simulated back in March 16, 2020. This was at near the beginning, to try to come to grips with how we can control this frightening infection. Because you recall, in China, it exploded very, very quickly. Within 10-day intervals, you could see the map of all of Eastern China filling up with cases very, very quickly. And so they came up with, there were 5 interventions that you needed to keep in mind. And they were isolation of all infected individuals and they should avoid contact with others, wear masks, and maintain distance of 6 feet from others. Quarantine individuals who had come in contact with that infected individual should agree to avoid contact with others for 14 days. Social distancing for those greater than 70 because of the higher risk of serious complications. And then 4 was actually social distancing the entire population. And finally, closing schools, universities, and businesses. And what they pointed out is if you did all 5, you could suppress the spread. And the R sub naught, or the reproductive rate, would drop below 1, and the pandemic would go away. If you chose mitigation, that is isolation, quarantining, and social distancing, you would mitigate, but you would slow the infection, but you would not bring the reproductive rate below 1. So then they modeled this, and this, I think a lot of people paid, the good news is a lot of people paid attention. They claimed that if you did nothing at that time, the United Kingdom would have 510,000 deaths, and the US would suffer 2.2 million deaths. And the curve, the upper curve is just the whole graph. The lower curve is a blow up of the lower part of the graph. And look at the red line. This is the really important line that they were concerned about. And that is the number of ICU beds on average within the health systems. And you can see that if you didn't do no intervention, that you would exceed the number of ICU beds by really almost 100-fold. So it was really clearly you couldn't do nothing. If you chose mitigation, that's the orange line, you see that within a short period of time, you also would exceed the number of ICU beds and outstrip the health system. So suppression, the green, was the recommended approach, because then you would not outstrip the health system. So I think you all heard this back in March, April, May. We must flatten the curve. That is, slow the spread so that the number of cases never exceeded the health system's capacity. Now I'm coming to the Greek myth about Pandora's jar, sometimes misstated as Pandora's box. It's actually, when you look at the original Greek, it's actually Pandora's jar. And I had Bruno Lucchese, he's a very famous sculptor who my father knew very well and I know very well. I asked him to draw Pandora's jar and adapt it to COVID-19. And what happened is Zeus was angry at Prometheus. And so he created a jar that contained all the pestilence of the world. And he also created a very curious and beautiful maiden called Pandora. And he knew that Pandora would be curious and she would open the jar. And when she opened the jar, she would release all the pestilence of the world to spread the epidemic throughout. And that is exactly what has been going on in the world and the United States. Pandora's jar has been left open. And as a consequence, there has been an excess of infection. And you can see the little viruses, the spike proteins, and an excess number of deaths as indicated in this image. Now, let's look at, this is April of 2020, because I think it's very instructive as to how different countries reacted to the infection. Now, the vertical axis is number of deaths, daily deaths in log scale, and the horizontal axis is days. The days since the average death passed 3. And what you see here, the stars are at what point different countries intervened with infection control practices, shelter at home, isolation, and case finding, and quarantining. And what you see is South Korea and China, the 2 stars here, they intervened when there were only 3 deaths per day. So they intervened very, very quickly. And you can see that as a consequence of this, South Korea, the pale blue line, flattened out very, very quickly. You can also see that China, which had a much larger population, originally went up, but then rapidly flattened out as a consequence of rapid intervention. Now, let's look at Italy. Italy waited until there were 80 deaths per day and over 800 deaths before they intervened. As a consequence, during that period, Italy had the highest death rate of any country in the world, and it devastated their health system, overwhelmed. And you remember the pictures of patients in the hallways and the devastating consequences to both healthcare providers and patients. And then let's look at the U.S. That's the red line. And there are no stars on that red line because the U.S., some states intervened briefly, but the majority of states really didn't take significant action because their governors were very cautious and did not want to intervene. Now, there are a fair number as a consequence of the Imperial College simulations that did briefly encourage shelter at home. And obviously the businesses suffered and schools were closed down. And so in October 2020, in Great Barrington, Connecticut, scientists got together and created a declaration saying that they had grave concerns about damaging the physical and medical health impacts of the prevailing COVID-19 policies, and they recommended what they called a focus protection, which really was basically, let's return life to normal. We don't want lockdowns, immunity. We want natural herd immunity. That is, allow everyone to go about their way and reach and get infected and gain immunity as a consequence of infection. And we'll just keep those that are older and have a increased vulnerability with immune suppression. We just tell them that they have to keep isolated, and everybody else can go about their business and have a normal life. And this was restaurants and other business should open, arts, music, sports, and other cultural activities should resume. So just to review what herd immunity is, because this is the key, I think, to the appropriate policies and the misguided policies of the United States. It's defined as resistance to spread of an infectious disease within a population that is based on pre-existing immunity of a high proportion of individuals as a result of previous infection or vaccination. And the level of immunity that's required is somewhere in the range of 83 to 94%, depending on the pathogen. So what the Great Barrington Declaration was stating in simpler terms is we propose natural herd immunity. Now, the word natural, that sounds really good, nature, natural foods. But in this case, as I'll go over, it's not natural at all. So, and Sweden actually followed this policy, and I'll show you what happened in Sweden. The advantages of this policy are government doesn't have to do anything. Everybody's free to do whatever they want. Infection control practices are ignored, and business goes on as usual. The problems, you overwhelm your health system. There are millions of unnecessary deaths. And the other big problem, which we are appreciating but isn't emphasized enough, is when you get the infection, the degree of immunity is extremely variable. In mild disease, there's only a poor antibody response, which may be short-lived, while in severe disease, you can generate longer-term immunity. So I calculated, and this is back about 8 months ago, what would be the price of herd immunity in the US? Well, let's say 80% of our population of 326 million would have to become infected. So there would be 260.8 million infections. We know that the hospitalization rate is somewhere between 6 and 10%. That would mean that there would be 15.6 to 26.8 million hospitalizations. The problem, we only have 0.924 million beds in the US. So we would outstrip the bed capacity by 17 to 29-fold. And the death rate has been pretty consistently in the 1.7 range. And so if you calculate the number of deaths you'd expect, it'd be 4.6 million deaths, even much higher than Imperial College had predicted. And let's look at Sweden. This is December of 22nd of 2020. They had 787 deaths per million. And when you compare that to the surrounding countries of Denmark, Finland, and Norway, that was 4.5 to 10 times the death rate. And so Sweden realized that this was a flawed policy. They fired their health minister, and they adopted the approaches of Denmark, Finland, and Norway using infection control practices. It's interesting, at that very point, we had 1,041 deaths per million. So we were also clearly following a natural herd immunity approach. So what about herd immunity through vaccination? And I think we know this very well. It's a controlled approach. It decreases hospitalization, decreases death. It has the potential to confer long-term immunity for everyone. It's historically safe and effective. And we all know the stories of polio and smallpox and measles and mumps and Haemophilus influenza and pneumococcal vaccine and influenza vaccine. They're all highly effective. and have accomplished this task. And this is back in December of 2020, the initial trials of the Pfizer vaccine. And here we are comparing the blue placebo, they received saline, versus the first injection of the Pfizer mRNA vaccine. And what the magic number is, look at day 12, the two curves, the orange curve is the vaccination, the blue curve, the placebo. At day 12, the vaccination curve flattens out dramatically, and there are no more additional cases. And this is after a single injection. And what they calculated in that study was that the efficacy was 94%, 94% protection of mild to moderate disease. Similar to the other mRNA vaccine, Moderna, similar efficacy. And then the J&J, which is a DNA virus or DNA vaccine, that had about a 78%, and the AstraZeneca about a 78% efficacy for mild to moderate disease. These were all highly effective vaccines. And the other thing I think we all know is they are incredibly safe. They have the safest profile of any vaccine we've ever given. So we all started to get vaccinated, and along came the Delta variant. So what is this Delta variant? Well, it has 12 mutations in the spike protein, and I'll go over in a minute the pathogenesis and why that's important. Particularly, there was a mutation at 478, tyrosine to a lysine, which increased the affinity of the spike protein for the ACE2 receptor on human cells. And the second really important mutation is the P681R, a proline to an arginine. And this is the furin cleavage site. And what happens is when the spike protein binds, there's a furin, the host cells have a furin, this enzyme that cleaves the spike protein, changes its conformation, and immediately enters the cells. So binding more tightly, cleaving more readily, allows entry more efficiently and more rapidly. It's estimated as 60% more efficient spread than the Alpha variant, which was another variant that was started in the UK and spread in the US. But the Delta beat that by a huge amount. And the reproductive rate, 5 to 6. Remember, the original virus was 2 to 2.5, and some have estimated that reproductive rate as high as 8. And UF contact tracing revealed here that the reproductive rate was 5. Now let's just go over the pathogenesis, what this means. Well, the virus with its spike proteins drawn here binds to the ACE2 receptors, and with these variations in the Delta variant, these mutations, the virus entered cells endocytosed more rapidly and efficiently, 10 times more rapidly. Then once it gets in the cell, the RNA from the virus is replicated through a replicase, generating a viral RNA, and also some of the RNA is transcribed into the surface proteins of the virus in the endoplasmic reticulum. And the RNA that's reproduced forms nuclear capsids, and then it comes in contact with the endoplasmic reticulum and coats the surface with the surface proteins, including the spike protein. And then it's surrounded by a vesicle, and then it's exotosed, and then the virus gets into the serum, into the saliva, infects adjacent cells, and gets into sputum and saliva. And the viral assembly and vesicle formation in the Delta variant has been found to be 10 to 100 to 1,000 times higher. So the original virus, an individual cell would produce 100 virions. In this case, it could be 10,000 virions. So a much higher number of virions. So with the Delta pre-symptomatic, you've got the 10 to 1,000-fold higher concentrations of virus in the nose, explaining why this spreads so easily. And the incubation period, because of the rapid entry, is 2 to 3 days rather than 4 to 5 days. And when we look at the infection with regards to households, it is more efficient. And in India, it has been found that although I cannot find any publications, but I worked with some doctors in India, and their experiences with 90% of India household contacts did contract the infection. And so Delta variant is equivalent in its efficiency of spread to that of chickenpox. And the other big problem is the efficacy of the different vaccines was decreased with the Delta variant, perhaps primarily because of the high concentrations that an individual is exposed to. And in the nasopharynx, IgA levels are very important. And IgA is relatively transient or short-lived after vaccination. And therefore, at 3 to 6 months, the amount of IgA is lower, explaining why some that are vaccinated can still become infected. The AstraZeneca was, with a wild type efficacy about 73%, dropped to 60%. The J&J, there were serum neutralizing titers, which were 1 to 300 to 400 with the original virus, dropped down to less than 1 to 30, which was very disturbing. Pfizer, remember, was 88%, was about 84% with the first dose, dropped to 36%, and was 94% with the second dose, dropped to 88%. And Moderna is similar. So a modest drop from 94 to 88%. And the problem with high numbers of unvaccinated being infected and with very high viral counts, this increased the likelihood that someone was vaccinated become infected. And what they found is, at least in the early, very early phase, that the viral counts in the nasopharynx of the vaccinated were similar in high concentrations to those that weren't vaccinated. So this, as a result, some vaccinated, particularly the elderly in Israel and Great Britain, were becoming hospitalized, and as were the immunocompromised. And here is a graph showing Israel, what happened in Israel, as far as this is the death rate per 100,000, a 7-day average for those over the age of 60. And you can see the orange is the deaths in those that were unvaccinated, clearly much higher, but with 2 shots, this is after the Delta variant, there was a moderate increased death rate over the period in August and September. If you had a booster shot, you can see that the death rate was almost flat. And here, this shows in the US, the difference between vaccinated versus unvaccinated with regards to hospitalizations, even as the Delta variant came into play, you could see that those were unvaccinated. There was an extreme surge, 90 per 100,000 hospitalizations, which is just incredible. While those that were vaccinated, it's very low. There was some breakthrough, approximately 5 per 100,000 versus 85 per 100,000. Now, I wanted to look at the disease activity at the peak for the Delta variant surge. And this came about September 17th in 2021. And the CDC has a map showing community transmission by county, and they classify it as high, substantial, moderate, and low. And what they found at that point, you can see the entire United States had a high community transmission rate for every county. And if you looked at Florida at that time, you can see here is the Alachua County, Gainesville. We had at that point 69 per 100,000, very high. But the outlying counties, look at this, 125 per 100,000, 117 per 100,000, 83 and 93 per 100,000. Look at Miami-Dade. They were down at 50 per 100,000. Now let's compare. So here is the epidemic, the pandemic in Florida during this period. And you can see we had a major peak at the end of August, 29,000 daily cases, which far exceeded the other peak, the other two major peaks in July of last year and in January of this year. And when you look at the vaccination rates, what were the vaccination rates at that point? Well, you can see the Alachua County was at 57%. Look at the surrounding counties, 28, 39, 33, 35, and Marion County, 48% vaccination rate. And look at Miami-Dade. They had achieved 70% at that time. So in the areas with the high infection rates, they had low vaccination rates. And I just did a little linear plot, a correlation to see what the relationship between percent vaccination and infection rate. As you can see, it was a straight line with an R value of 0.87 and the highly, highly statistically significant. So the higher the vaccination rate, the lower the infection rate. So anybody tells you that vaccination doesn't help control the infection, just tell them about this curve. So the question comes up, what went wrong? I think the key is disinformation. Now, when we know the true facts, as I'm describing today, when we follow the guidelines of the CDC and other infectious disease experts, and they really have to be trained in infectious disease and epidemiology. Unfortunately, there are many physicians not trained that have drawn improper and inaccurate conclusions. So just because you're a doctor doesn't mean you understand the true facts. But when you do have the true facts, you are protected. You create a protective bubble. And this is a concept created by an associate professor, Annegret Hanois from Switzerland, who shared this with me. So you are protected when you have the right information. Now, when you start believing things that are not really true, that are not scientifically verified, then you burst that bubble. And as a consequence, you will become infected and your family will become infected. So disinformation is extremely dangerous. And it's critical to listen to infectious disease experts to protect yourself. Now, why are there so much disinformation? And I realized that I actually gave grand rounds on misdiagnosis in healthcare resulting in adverse events in our health system, deaths and serious injuries. And it turns out when you look at the causes of adverse events and preventable deaths, 30% of them are due to misdiagnosis or treatment delay as a consequence of delays in diagnosis. And so what I read a great deal for this grand rounds on the concept of metacognition, that is how our brains think and how we process information and how we draw conclusions. And in looking over the literature on delays in misdiagnosis in the healthcare system, there really breaks down into two major categories. Hasty judgments. Anchoring is probably the biggest. That is, the physician or the person caring for the patient fixates on one diagnosis and they just stay anchored to that no matter what. They have premature closure. That is, they draw that conclusion and they don't consider any additional information. There also can be framing bias. For example, a cardiologist may think that the diagnosis is related to the heart, when in reality it's related to the lung. So you look through one perspective, and that can lead to misdiagnosis. And then bias judgments, confirmation bias. We see this all the time. The physician only takes in the lab data that fits with their diagnosis, and other data that doesn't fit, they will just ignore. And then one that we have to be very careful of is visceral bias. That is, particularly patients who are been taking pain medicines that may be somewhat addicted. They may come into the emergency room complaining of severe pain, particularly abdominal pain. And because the doctors are suspicious of these patients, they may ignore their complaints. And as a consequence, we've had several cases, and this is reported in all health systems, where their individuals have had acute abdominal pain and ruptured viscus that was delayed because of visceral bias. And we really have to be very, very careful about that. And then I don't think this one is too common in healthcare, but is reported, and that is what's called epistemic hubris, expression of unwarranted factual certitude. I know this is the diagnosis, and I'm not changing. I'm not open to new information. Now, these are what cause delay and misdiagnosis that lead to unnecessary deaths and injuries in patients. But I realized that these same errors are being made by our politicians and others who are spreading disinformation. For example, anchoring. What has happened is a number of governors, particularly the governor of Florida, has anchored on the Great Barrington Declaration. He feels very strongly that our schools should be wide open. We don't need masks. We aren't going to mandate vaccines because natural herd immunity will take care of the problem with our kids. He won't. He has ignored the Swedish experience. He has ignored the tremendous efficacy of the vaccine and its ability to prevent harm to our children. And he really prematurely closed and just has not allowed that new information to be applied. And he has demonstrated incredible framing bias. He is only looking through the perspective of the business world and claims that any kind of infection control practices are bad for business. Has he ever visited one of our MICUs? Has the governor of Texas ever visited an MICU? He has ignored the perspective of healthcare, those that are working in healthcare. He has ignored the perspective of families who have lost loved ones, and he has ignored this perspective of patients who have suffered greatly and have managed to survive COVID-19. So all these forms of hasty judgment are clearly apparent in a number of our government officials, including our governors. Now, how about bias judgments? Confirmation bias, absolutely. There have been cherry picking of evidence. For example, masks, there was a flawed study that was retracted saying that masks cause CO2 retention, which was not true. There have been studies that claim that masks don't reduce the rate. Well, the CDC has released a study that showed that in school systems, implementation for masks for a 2-week period religiously reduced the number of infections to 1/3 they are in areas where masks are not being used. There is no question that masks are effective. And similarly, they pick up data on vaccine side effects and claim that the vaccines are dangerous, which is simply not true. Visceral bias, I think, is very, very important. Don't Fauci my Florida. If that isn't anti-intellectualism, if that isn't visceral bias, I don't know what is. So infectious disease experts such as myself have been pushed to the sidelines and ignored because they're too intellectual. They're a pie in the sky. We don't believe them. And then I really think that what I've come to conclude is that this virus is like a lie detector test. If you believe lies, you get infected. And then the epistemic hubris, we have actually experienced this in the hospital, particularly when with this ivermectin. I've had patients actually call me, swear at me, saying that we need ivermectin and we know that it works, even though there's a controlled clinical trial proving no benefit. And so they're sure they're right. and they're not open to new information. And finally, and I think most egregious, is politicizing scientific facts. And in the editorial, I pointed out that, and the big problem is that we should have freedom. Mandates interfere with our freedom. We should be free to become infected, to become critically ill and die. And we should be free to become infected and spread it to others. And as a consequence, and I looked at, actually on October 15th, I looked at the death rate, the daily death rate in different states, and found that what turned out to be is that those states that were the freedom states, West Virginia, Idaho, Wyoming, Florida, and Texas, they had death rates that were 3 to 6-fold higher than New York State or California, states that had actually followed infection control. So we know that when you leave Pandora's jar open, more and more people are infected and more people die. And we, as a consequence, we have the highest number of cases and deaths in the world. There has been no uniform response. It's varied from state to state. Shelter in place was brief and quickly abandoned. Vaccine uptake, unfortunately, has been variable. Disinformation has been a major challenge. And politicians have made diagnostic and treatment errors, including anchoring, framing, confirmation, and visceral bias, epistemic hubris, and a politicized science. And experts are not being heard because of the strong anti-intellectual attitudes. So I want to end by asking all of you, how do we assure that science prevails? So that I end, and I want to entertain questions.
Hello, Fred.
Hi, yes.
Thank you. Thank you,
Bill
Fred.
Bill Kim.
We have a question on Zoom.
Bill Kim has a question.
Oh, Bill Kim. Do you have a question, Bill?
Yes, I do. Very
Go
nice
ahead.
presentation, Fred. I learned a lot, even in spite of the fact that I've been following this pandemic with a lot of interest. As a pharmacologist, my question for you is, well, first of all, what can we do to avoid such a poor performance during the next epidemic? And even more importantly, I'm curious why we can't find drugs, small molecules that can interfere with the replication of the virus. Can you provide some feedback here?
Yeah, what was the first part of the question?
Well, what do you recommend be done?
Oh yeah, okay, going forward.
To avoid the next pandemic.
Yeah. Well, Obama, I think the end of the Bush administration and the beginning of the Obama administration, they actually had a special task force that made very profound and correct recommendations of what should be done. And it's very clear, it has to be a national response. It cannot be at the state level. And that the CDC really has to, what they're recommending needs to be implemented. And there has to be an actual group that's listened to. One of the big problems is because it was so fragmented, we got mixed messages everywhere. And the other problem is we didn't understand the virus. So initially we said certain things, like at first masks weren't important, which turned out to be absolutely categorically wrong. But we switched, but we didn't sort of change the message in a way, it led to distrust. And then those that were which we've had an anti-intellectual, this visceral bias for a long time. Believe me, the social media, Fox News has been pushing, dumping on intellectuals for over a decade. So we were set up for this. It's very interesting. I just was reading today that, where is propaganda and disinformation at the highest level? Russia. Well, guess what? Russia is now having the most severe surge of any nation in the world. And they have a very low vaccination rate because there has been propaganda for decades and decades. No one trusts anybody. So you can't get an accurate message across. Well, unfortunately, all this disinformation for all these years and all this anti-intellectualism has created a terrible problem. And as I said, this virus has served as a lie detector test. If you believe the lies, you get infected. That's what's happened, because the virus doesn't care whether you're Republican or Democrat. It just cares what you do. So we really are going to need to have a central body. It has to have authority, and it has to be able to mandate. Mandate is absolutely, you have to mandate, because with so much disinformation, we've seen that the changes in attitude, there are not being changed. You can't talk to people. You cannot convince them. And there's actually a study in JAMA looking at, in April, what the attitudes toward the vaccine were compared to June, July, when the Delta variant came, when there was a lot of information pushing the vaccine. Well, those that said they were opposed to the vaccine in April, there was absolutely no change in their attitude toward the vaccine, despite the Delta variant and despite strong messaging. So you're not going to convince people. So that means and that's well known. Rogers' innovation curve has shown for over 2 decades that there is a group, about 25% of individuals, somewhere between 15 and 25%, they call them laggards or traditionalists. They will not change unless they have to. They will not. So if we want to reach herd immunity, which is at 80 to 85%, we have to deal with that group. So mandates are very important. Now, the second, as far as small molecules, actually Merck has a drug, which is oral, that it looks very, very good. And they've done a study of, I think, about 800 individuals. They showed a 50 to 60% reduction in hospitalizations when you take this drug for 5 days. And it's an antiviral agent, and it suppresses the virus. What we've noticed is that if you can start remdesivir very early in the course, you halt the progression. Remdesivir antivirals will not reverse the damage that's been done, but they will halt further damage. So if you wait too long, the damage is done and you won't get any. If you can get them within the first couple of days of symptoms and signs, you will shut it down and they will never end up in the hospital. So I think this Merck drug is a godsend. And really, I hope it's actually under EUA, is being evaluated right now. I think that will be the approach that we need to take, along with, obviously, vaccination is very important. Now, one really pathetic, I think, straight tactic of the governor is to say, oh, I'm not going to talk about vaccine, but you need to get monoclonal antibodies if you get infected. And I can tell you, the monoclonals do work if you give them within the first 5 days of symptoms before you start generating your own antibody. But the logistics of managing this, we found was impossible. I actually said so they were all family medicine was going to call me when they had a case. I got 3 calls in a month. It just does not work. You can't. So what happened is, I can tell you, is what happened is they have these centers for monoclonal antibody. Anybody that had a positive test could get it. They didn't use any criteria, and this was supposed to use for high-risk individuals. They just gave it to anybody. So I think the estimate is that it reduced hospitalization by 2%. It just did nothing. But he uses that to counter, oh, I'm very much in favor of the science because I'm in favor of monoclonal antibodies. Really a really malignant tactic in my view. So, yes.
Thank you. We have some comments here. The first one is from Roy Wiener. He asked, what are the cellular and humoral mechanisms that result in protection?
Well, we don't know totally, but we do know that neutralizing antibody, but when you do neutralizing antibody, you can get the titer of anti-IgG or NIGM to the spike protein. You use an ELISA assay. It's very simple, but that just you infer that that's causing a protection against the virus. But you can actually dilute the serum and put it on tissue culture cells that have the virus in it and dilute it out that way. That's what neutralizing antibodies are. And we know that, for instance, Moderna, you could get a very high 1 to 1,000, 1 to 800 neutralizing antibodies. And that's what I was talking about. The J&J, the neutralizing antibodies went from 1 to 300 to 1 to 30 for the Delta variant. So that's humoral immunity. And then cell-mediated immunity, the T cells recognize the antigens, and then they activate killer T cells that destroy cells that are infected with the virus. So those are the predominant two mechanisms.
Yeah, thank you. We have several comments and questions here, so let's move along.
Yeah.
Yeah, Paula, you have a question?
Yes, thank you, Dr. Southwick. It's hard to argue with the current vaccination routes since they seem to be 95% or so effective, but I wondered what your thoughts were on any future approaches with something like, say, mucosal immune vaccines. That was one question for you. And another question might be, when we refer to DNA and RNA vaccines, I think there's a lot of confusion in the general population. And
Right.
people's general understanding of DNA is their genes and their chromosomes. And oh my gosh, you're going to infect my DNA with DNA from virus. So I think when we refer to that, you know, especially with the J&J, which is a DNA, you know, that's not, you know, that's an adeno-associated virus approach. So it's nothing that's going to integrate into people's DNA.
Right,
And certainly
exactly.
the RNA approaches aren't either. But how do we communicate that more effectively to people?
It's really difficult. For instance, my sister-in-law, who had a microbiology degree and worked in, in actually a medical field, she doesn't like genetically modified food. She won't eat genetically modified foods. So the same people that are fearful of genetically modified foods are afraid of the mRNA and DNA viruses of vaccines. And it's not logical. And you can't, unfortunately, you just can't overcome that. We've spent hours and hours and hours. And what I would hope is that there is a good protein vaccine that actually made it to the EUA, but somehow they haven't distributed it. I can't remember the name of it, but it's very good. It has an excellent efficacy. And there they just purified the protein and used an adjuvant. That's just like the pneumococcal vaccine, the Moffitt's influenza vaccine. And I think it would be nice to have that in our armamentarium for those that you cannot convince that the mRNA and DNA are not going to integrate. mRNA lasts probably, I think probably an hour or two. You know, when it gets into the cells, it gives a signal to produce the protein, and then it's destroyed. mRNA is very transient and very susceptible to RNases. Having worked with it, experimentally, you look the wrong way, and RNA is destroyed. So what we usually do is we convert RNA to DNA quickly because the RNA is going to be destroyed. So that's the beauty. I think the mRNA vaccines are just so elegant. And they present the proteins in a very natural way that seems to really allow processing by T cells and B cells in a way that no other vaccine has. And that's why we achieve such great efficacy. The other beauty of the mRNA vaccine, there's no protein. There's no egg. There's no nothing. There's nothing to get allergic to. There are a couple salts in the RNA and a lipid. It's pretty much foolproof. So, there are a couple, autoimmune phenomena, which would happen with any vaccine, but it's very minimal. And that's why I think mRNA is the way I predict that a lot of vaccines will shift in mRNA in the future. The influenza vaccine, you could switch the outer type very quickly. Within a month, you could generate a new vaccine Instead, we're actually anticipating a whole year to try to decide what the capsular types are, or the outer coat types are, when we could do it, if we were to do it more closely to when the influenza is going to surge, we could be more accurate in our design of our vaccine. So unfortunately, I don't know any way, having tried, I don't know a way to overcome that fear about DNA and RNA.
Okay, let's thank you, Fred. Let's go on to a chat question from Pat Harden. It says, can you explain the article yesterday stating that masks in school are not effective? It compared PK Young voluntary masking to Alachua County Public Schools and 1,000 students. Are you aware of that?
I haven't seen that study, but it's all a matter of how they're wearing the masks and how well it's being implemented. And fortunately, if kids don't believe in it and the message is muddled, they will bring it down below their nose. When they're not being seen, they won't be wearing the masks. So it's not, so I suspect that the implementation has not been what it should be in any part of Florida. So that doesn't mean masks don't work. Yeah, masks don't work if you don't wear them properly. That's what it tells you.
Makes sense. Let's go to Shirley. Shirley, you have a question?
Yes, Fred, I really, really am so impressed that you've identified how people get caught up in misthinking, incorrect thinking, going down wrong paths. Now that you've identified that, I guess the task is, how do we reinstall more critical thinking? Is it all going to be about trust in government to rebuild trust in scientists? Or can you build a treatment plan for all of those things you've identified? Or do you think everybody dying who wasn't vaccinated is going to change people's minds? Is everybody still going to
that's $1 million question. And that was actually my final question was, how do you get people to adopt science and use a scientific method? And, one of the things about science is we continually generate hypotheses and test them. And then we see what the results are. We change, we adjust, and we do that continually. And that's what you need to do in a pandemic. It's a very dynamic process. It will be changing. We have to trust those conclusions, and we will eventually come to the truth. But too many people are not trained in the scientific approach, and everything is digital, yes, no, and everything is black and white. And unfortunately, nothing is black and white. And we need to really train. I think this is why in schools, we have to train critical thinking. Now, what I would hope is that over time, people will begin to value in politicians who are critical thinkers. We don't want dogma. We can't afford dogma. We can't afford anchoring. We can't afford narrow, limited perspectives. These are deadly. These are deadly characteristics that we should not be voting for. And I think these, the reason I did the editorial, I'm hoping that individuals will now bring this up, as characteristic we don't want in our politicians. And if they do that, hopefully DeSantis will never be elected again.
Yeah. Well, we have such specialists in mind manipulation toward disinformation.
Yes.
Maybe we need to employ those same people.
Yeah, well, the problem is, yes, the advertising field has been very effective at promoting everything. And they can promote things that aren't good for you very effectively, unfortunately. So I do think that the business world has learned how to make things that are not correct sound correct. And I'm always astounded when I listen to a certain talk show host on Fox News. It sounds sort of correct, but I know it's wrong. So it's very tricky. It's not.
I think right along those lines, there's a comment in the chat box from Anne-Marie Rizzo. She says, one problem is scientists with correct information and guidance don't seem to be reaching the uneducated at the places they consult. Does anyone know of organized efforts to correct disinformation as it happens on popular platforms?
Yeah, I don't know that anybody is doing that. I mean, it's such a hard job to do, and I can tell you I got one really pathetic hate mail over my my opinion piece, and there are people that are very vitriolic, and you talk about visceral bias. It's insane how extreme it can become. So it's very difficult. And one of the problems that's come up is public health officials are quitting in droves because their lives have been threatened, their houses, their families have been threatened over their trying to institute scientifically based policies. So I think it's very, very difficult in this environment to do. And I don't know that there's any effort at this point.
Yeah. Okay, we have a hand up, David Poliger. Please unmute yourself and ask your question.
Thank you for a very, very important and clear presentation, during which you mentioned that towards the end of the Bush administration and throughout the Obama administration, the White House had created a structure for dealing with pandemics.
Right.
But you didn't mention that early in the Trump administration, this was dismantled.
Yes, right, exactly, yes.
Do you know if it's being reconstituted?
I suspect so. I haven't heard about that yet, but it certainly, I would predict it will be. Yeah, it really has to be. I think right now, the administration is just trying to get everybody vaccinated. And then I think once the dust settles, if they can get enough people vaccinated, if we could get up to, and then the other problem is, there's been a waning what happened in Israel and is happening here to some extent. Those who were vaccinated back in last January, their immunity has waned, so they need a booster. So we've got the problem of the booster. We've got the problem of the young children, convincing parents to get them vaccinated. And we've got to get a higher percent of the age 12 to 16 vaccinated. So I think they're focusing on all those things right now, but I'm sure that there's going to be another commission that will handle that. Has to.
Thank you.
Okay, there's a in the chat box from Kathleen Heyman. Do you anticipate a variant arising soon that could get around current vaccinations?
Well, it's a big worry because when you have a high percent of people that are unvaccinated, the way you generate new mutants is this virus does not grow outside of human, of a host. It has to be infected, get into human cells. And when it gets into human cells, the problem is the replicase is very inaccurate. It doesn't have good proofreading. So it does make errors. And if an error gains function, in other words, is more effective at spreading, it will take over. Now, my thought on this is that I don't know if you can do better than the Delta when it comes to ability to spread. Now, what could happen is you could have, if we get more people vaccinated, we could get a variant that's confirmation is so different that the vaccine efficacy will drop. That could happen. And the longer, that's why it's so scary that people won't get vaccinated, because the longer we have a large unvaccinated population, the more likely we are to get a new variant that will escape the vaccine. Now, the other important concept, remember, the Delta variant came from India. So it doesn't necessarily have to come from the United States. In fact, it's unlikely to come from the United States. It's more likely to come from a country where there isn't sufficient vaccination. Now, because there's no vaccination, the type of variant probably won't be a vaccination escape variant at this point. It'll just be a gain of function for other reasons. And the Delta didn't escape the vaccines very much. It was mostly a gain. It replicates, it gets into cells more rapidly and replicates more rapidly. So I don't think there's going to be one, but I know all predictions are questionable.
Yeah, you just mentioned about the Delta variant coming from India, and I've wondered about this. I've been wondering in India, the Delta variant really came in like a hurricane
Yes.
in April and May, and people were dying left and right. And then all of a sudden, it's gone. It's just gone.
Yeah, I think
Why?
what happened is they, as you know, in India, there are large crowds, families are large, housing, a lot of people are in large households, multi-generational. So what happened is and we think it's like 90 to 95% of households become infected if one person gets, an index case comes in. So I think they achieved natural herd immunity. That's what happened. Now, the problem is it may wane over the next, natural herd immunity is usually shorter lived and not as effective. So we could see a new surge but the good news is, as you know, India is the leading vaccine manufacturer in the world. And they are really pushing hard now to vaccinate everyone. And they're doing a very good job of that. So the hope is before the waxing herd immunity, they will get the vaccine. One really interesting concept that's come out very recently is if you were infected, it's likely you only need a single shot because you've already had the first shot. And it turns out that the degree of protection after a natural infection plus vaccine is equivalent to 2 vaccine shots. It may even be a little bit better. So why, there's a guy named Mina at Harvard that's recommended this, for instance, in children. I bet you 30 to 40% of all children now have been infected. And often we're asymptomatic. What one thought would be, you get given the first dose of vaccine and you get an immunoglobulin anti-spike protein or antiviral protein antibody test. If that's positive, you don't need a second dose. If it's negative, you need a second dose. It would make it logistically a lot easier because not everybody would need 2 doses, and it would save a lot of vaccine.
Thank you. We are running over time, so let's just go to the last question. Rick Gold, unmute yourself. Yeah.
Thanks very much. You talked about different errors in thinking and dealing with the issue. And I'd like to add, perhaps ask for your response, that looking at it from a national perspective is inadequate, that when you're dealing with a disease like this, you have to look throughout the whole world as in terms of from the very beginning, making sure that there are adequate responses worldwide rather than focusing only on the country in which we live. And from another perspective, in terms of the decentralized nature of our health approach in the US, looking at it nationally is not as effective as looking at it in each of the states. And that, if at the national level we cannot control the response at the state level, that's a wrong way of looking at it as well.
Yeah, I completely, the WHO should have ultimate authority here, working with the different country public health institutions. There have been some debates between the WHO and some scientists. For instance, the WHO has not been as embraced the aerosol concept, which I think they should. And they've been somewhat resistant. So some of the policies aren't as rigorous as they might be. But I agree, we've got to worry about all countries. Now, as far as the states, I didn't quite understand what I hear you saying is that every state's going to have to do it their own way. That doesn't work. We've proven that we've done that experiment. For instance, Idaho, their whole hospital health system is outstripped Alaska. They've actually done this. They call it catastrophic policies, health policies. They are actually deciding who can get into the hospital and who can't. They are sending people home to die. That's what's happening when you use that kind of policy. For instance, Idaho has now a commissioner of public health that has no medical or scientific background at all. And he is spewing that the vaccine is not good for you and all kinds of misinformation. We can't have that because people in those states are going to travel to other states and spread the virus. So it really has to be, I agree, ideally it should be a worldwide, everybody should do it the same way. They should be all following the best practices, and that would be the ideal. That's what we should have. Good question.
Thank you. Thank you, Fred. I think we need to end here. If you still have questions, feel free to send them on to me and I can pass them to Fred. Thank you very much, Fred. That was an outstanding and very impassioned talk. Thank you very much. Next week will be our final talk of this series. That will be on peripheral neuropathy. So hope to see you next week. Thank you all.
Thank you, Priscilla. Bye.